There's a very specific image we all have in our heads when we think about healthcare. It's that classic consultation. You're sitting there, maybe on an exam table, and a doctor walks in.
Right, holding a chart.
Exactly.
Mhm.
They look at your vitals, they ask how you're actually feeling, and then they make a decision
Yeah.
based on years of training and the person right in front of them.
It's the bedrock of that whole relationship, isn't it? The patient-doctor relationship. We just assume the authority lies with the human being in the white coat.
But the documents we're diving into today, they suggest that whole scene is, well, it's becoming a piece of history. A performance almost.
Yeah, performance is a good word for it.
Because in a growing number of cases, the doctor in that room has lost the power to decide when you go home or when your treatment should stop.
That authority has been outsourced, and not to another better doctor, not to a specialist.
No, it's been handed over to an algorithm.
And that is the terrifying reality at the center of all this. We're looking at the invisible machinery of modern healthcare denial.
We've got reports, legal filings, investigations, and they all paint this picture of a system where the threshold of care, the point where support just stops. It's no longer determined by your body's needs. It's determined by a profit-maximizing code.
And we have to be really clear here. This is not hypothetical. This is not some sci-fi future. It's happening right now to real people.
People like Jean B. Locken and Dale Henry Tetzloff, I think we have to start with them because their stories just shatter that illusion that the doctor knows best.
They're just heartbreaking cases. Jean was elderly. He had a severe leg fracture. Dale had suffered a stroke.
So pretty standard, serious medical events. They're in care facilities. They're doing the work to get better.
And in both cases, the medical teams on the ground, the actual humans watching them every single day, were completely clear.
What'd they say?
These men are not ready to leave. They needed more time, more rehab.
So if you just follow the traditional logic of medicine, that's it. Discussion over. The doctor says, stay, you stay.
Right. But then, just abruptly, their coverage was cut. Payment denied. Discharge ordered.
And the denial didn't come from another doctor who came and looked at them. It came from a piece of software. An AI model just looked at their data and said, time's up.
It overruled the doctors. And that's the fundamental shift we have to get our heads around today.
So that's what we're going to do. We're going to try and reverse engineer this machine. And to do that, we need to unpack 3 specific concepts from the source material. First, we have to look at the victim.
A demographic the researchers have labeled Alice.
Then we've got to look at the mechanism, a concept ominously called the killing line.
And finally, we have to talk about the motive, the incentive for sickness, how the whole medical industrial complex is designed.
So let's start with the people. Who is the system actually targeting? When I first saw that acronym, ALICE, I assumed it was, a software name or something.
A lot of people do, but no, it's a socioeconomic term. And it's a crucial one because it probably describes a huge number of people listening right now. ALICE stands for Asset Limited, Income Constrained, Employed.
Asset limited, income constrained, employed. Okay, let's break that down because that last word, employed, seems really important.
It's everything. We are not talking about people below the federal poverty level. On paper, Alice households look fine. They're working. They earn more than the poverty line.
But they're not thriving.
Not even close. They are just treading water. They make less than the basic cost of living for their area. So yeah, they can pay their rent, buy food, maybe put gas in the car, but that's it. That's what the sources call the household survival budget.
And there's a distinction, right, between that survival budget and a stability budget.
A huge one. A stability budget has a buffer. It's got savings, an emergency fund. Alice has none of that. Zero margin for error.
So if the car breaks down or a medical crisis hits,
the whole thing falls apart immediately.
So why does that specific financial profile, why does that make them the perfect fuel for this kind of algorithmic insurance model?
It's that first part of the acronym, asset limited. Think about Jean Locken's case. If an algorithm says, we're not paying for your rehab anymore, a wealthy person might just say, fine, I'll pay for it myself.
You'll write a check?
They'll write a check. Alice can't do that. They physically cannot pay out of pocket.
So their only option is to fight, to appeal the denial.
But remember the last letter, employed. They're working jobs. They're raising kids. They do not have 40 hours to spend on the phone with bureaucracy. They don't have the money for a lawyer.
So the system is it's banking on their exhaustion.
It is weaponized friction. And the numbers prove that it works. This is the statistic that I just couldn't get out of my head.
Go on.
Insurance industry data shows that only about 0.2% of policyholders ever appeal a denied claim.
0.2%.
Okay.
Statistically, that's nobody.
It's practically zero.
So 99.8% of the time, the algorithm just wins by default.
It wins by default. The insurers know that if they cast this wide net of denials, the vast majority of people, the Alices of the world, will just quietly give up. They'll go home, or their family will take on the burden, or they'll just suffer.
That is just incredibly bleak. The business model isn't managing risk, it's managing passivity.
That's it, exactly. Alice is the path of least resistance.
Okay, so we know who is being targeted. Now let's look at how. This brings us to the mechanism. The source material uses this phrase, the killing line. It sounds so dramatic.
It does, but it actually has an origin in animal ethics.
Really?
Yeah. In industrial farming, the killing line is the boundary where moral consideration just stops. It's the line where a living being is no longer treated as a who, but as a what? A product.
And in healthcare, that line is the threshold of care.
Exactly. It is the exact moment a patient becomes unprofitable. The second your care costs more than the algorithm says you're worth, you cross the killing line. The support is gone.
And it's all automated. The sources point to two specific tools here. Cigna's PXDX and UnitedHealthcare's NH-Predict. Let's start with PXDX, because the speed of it is just, it's mind-boggling.
PXDX is the perfect example of industrial-scale denial. It stands for Procedure to Diagnosis. And the investigation found that medical directors at the company were denying claims in huge batches.
And the average time it took them?
1.2 seconds.
1.2 seconds. I mean, I can't even unlock my phone in 1.2 seconds. There is no way a human being is reading a medical chart and making a clinical judgment in that time.
It's physically impossible. A proper review takes minutes.
Yeah.
What's happening is batch processing. The algorithm flags a bunch of claims, puts them in a pile, and a doctor just clicks deny all.
It's like clearing out your spam folder.
Yes, without checking to see if there's an important email from your mom in there, except here, you're not deleting a coupon, you're deleting someone's access to an MRI.
And then there's NH-Predict. This was the system used with the two men we started with. This one feels even more insidious. It pretends to predict the future.
Right. This one is used in post-acute care. So nursing homes, rehab facilities, it uses a giant database of past patient data, and it looks at a new patient and says, okay, statistically, people like this recover in 14 days.
People like this. That's the trap, isn't it? Because sure, the average person might recover in 14 days. But what if I'm not the average? What if I have a complication or I'm just healing slower?
The algorithm does not care about your specific biology. It only cares about the regression to the mean. It sets a rigid length of stay target. You should be done by Tuesday, and if you're not, the payments stop.
You know, there's this huge irony here that the source points out. About 15 years ago, there was this whole political frenzy about death panels. Remember that?
Oh, I remember. The fear that government bureaucrats would decide who lives and who dies.
Right, and it's so ironic. We spent all this energy fighting these imaginary government death panels.
That we didn't notice private companies were building real ones out of code. These systems are death panels. They're just privatized, automated, and hidden behind trade secrets.
But let me play devil's advocate for a second. Is it possible the AI is just? Right. Maybe doctors are too cautious and they keep people in care too long.
It's a fair question. Is this just about efficiency? But the data gives us what I call a smoking gun. Remember that tiny appeal rate, the 0.2%?
Yeah, a tiny fraction of people who fight back.
Well, we have data on what happens when they do fight back against NH-Predict. When those denials get challenged and a real human being actually looks at the evidence,
What happens?
they're overturned roughly 90% of the time.
Wait, 90%?
9-0. 90%. If my calculator was wrong 90% of the time, I'd throw it in the trash. I wouldn't use it to manage someone's health.
The error rate is staggering. It proves the killing line is not based on medical necessity. If it were, the AI would be right most of the time. A 90% overturn rate means the system is designed to be wrong. It's designed to be overly aggressive.
The error is a feature, not a bug.
Precisely. It's a machine designed to say no until someone with power forces it to say yes. And since Alice has no power, the no just stands. And the employees are trapped in it too.
Absolutely. The sources say that in some cases, employees are disciplined if they deviate from the AI's recommendations by more than 1%.
So even if a human case manager sees a patient who obviously needs more care, their hands are tied.
They can't approve it without risking their job. It removes human judgment, human compassion from the loop entirely.
Okay, so we have the victim Alice, We have the mechanism, the AI killing line. I
Yeah.
have to zoom out now. Why? What's the engine driving all of this? This is part 3, the incentive for sickness.
And this is where we have to talk about the medical industrial complex. The MIC, it's that whole web of pharma companies, insurers, huge for-profit hospital systems.
And the core argument from the source is pretty brutal.
It is. It's that curing patients is often way less profitable than managing their disease. A cured patient stops paying.
They exit the market.
Right. But a patient with a chronic managed condition, that's a subscriber for life.
And this isn't a new idea. The source gives historical examples. The one about stomach ulcers really stuck with me.
It's a classic case. For decades, the story was that ulcers were caused by stress. So the industry pushed antacids, things like Zantac, billions of dollars in revenue.
They managed the symptoms.
They managed the symptoms, but you had to keep buying the pills. Then it was discovered that ulcers were actually caused by a bacteria.
And the cure was?
A cheap course of antibiotics, one and done. But the industry dragged its feet on accepting that cure because it would have cannibalized their cash cow.
Wow. The notes also talk about for-profit dialysis centers.
Yeah, that's much more serious. The research shows that these for-profit centers tend to have higher mortality rates. But, and this is crucial, they also tend to use higher doses of really expensive drugs like epiwetin to maximize their reimbursements from the government.
So the incentive isn't get the patient healthy, it's maximize the revenue from each session.
It's all about extraction. And you really can't talk about the MIC without bringing up the opioid crisis. The source presents this as the ultimate example of the machine at work.
That was a completely manufactured crisis.
Entirely manufactured. You had companies marketing OxyContin as non-addictive when they knew full well that it was. They created a market of addiction that, in 2015 alone, cost the U.S. over $500 billion.
And the cycle is so vicious. They create the addiction, and then when regulations finally tighten, the market shifts to illicit fentanyl. And now this system charges to treat the overdoses and the rehab.
It's a closed loop. They manufacture the demand, the sickness, and then they sell the supply, the treatment. And this all connects to this other concept mentioned in the sources, disease-mongering.
That's the idea of taking normal life experiences and turning them into medical conditions.
Exactly. Things like mild bone density loss as you age or going bald. If you can give it a scary-sounding medical name and patent a drug for it, you've just created a brand new market. You pathologize normal life so that nobody is ever truly healthy.
Everyone is a customer in waiting.
Everyone. And when you combine that drive with the AI tools we just talked about, tools designed to cut costs the second those customers get too expensive, you get this perfect storm.
You get a system that's aggressive about recruiting you when you're profitable.
And absolutely ruthless about cutting you loose when you're not.
It's a chilling architecture. We have the incentive, the MIC, building the mechanism, the AI, to extract value from the victim, Alice.
And I think the most profound point the source material makes is actually a philosophical one. It connects this whole dynamic to the concept of speciesism.
Yeah, I wanted to ask about that. Speciesism is normally about how humans treat animals, right?
Right. We justify exploiting animals by claiming a superior status. We tell ourselves that because they are lesser, it's okay to use them as instruments, to turn a living being into a unit of production.
A hamburger, a test subject.
Exactly. And the argument is that the medical industry has started to adopt that same view toward patients. When an algorithm like NH-Predict looks at a stroke victim, it doesn't see a grandfather who wants to walk his daughter down the aisle.
Didn't see a who.
It sees a what? It sees a cost center, a data point that needs to be optimized. It instrumentalizes human life.
That really changes how we should hear the word efficiency in healthcare. We always hear people talking about making healthcare more efficient, and it sounds good.
It sounds good, but in this context, efficiency is just a euphemism for denial, and the system isn't broken. That's the hardest part to accept. If you look at the profits, the machine is working perfectly. It's functioning exactly as it was designed to function.
It just wasn't designed for our health.
No. Health is a byproduct, maybe. Profit is the directive.
That is a heavy realization to sit with. We're living inside a machine that's operating at peak performance, just not for our benefit.
And as these AI tools get faster and more autonomous, that threshold of care is only going to get sharper and harder to cross.
Well, that is certainly something for you to think about the next time you see a medical bill or hear about a new AI breakthrough in medicine. It's not just about the technology.
It's about the values programmed into it and asking the question, who do those values serve?
Precisely. That wraps up our deep dive for today. A sobering look at the algorithm of neglect. As always, thank you for listening. Take care of yourselves, and maybe double-check your insurance policy. We'll catch you on the next one.